Next up is Managing Essential Thrombocythemia in 2023, a talk given by Dr. Joseph Scandura at Weill Cornell Medical College here in New York. Joe, the floor is yours.
Morning. So I'm stepping in for Ellen this morning. She had an issue that she couldn't attend, so on short notice, I'm here. But you may have picked that up or thought that Ellen was shorter than you remember her and slightly more hairy. So yeah, I'm filling in for Ellen. If you have something you like, then you can compliment her. If you don't like it, throw the tomatoes on. I can get by. So who gets ET? It's a relatively rare disease, but there are about 80,000 people in the United States with this disease, and probably this is a vastly underdiagnosed disease. Hans Hasselbach, who's sitting here, has published a series from Denmark reporting that maybe up to about 2 or 3% of the population might carry some of the mutations that drive these diseases, and whether we catch them after they develop blood counts or before, they seem to evolve into MPNs over time. For reasons that aren't clear, at least to me, women are more commonly affected by ET than are men by about a 2-to-1 ratio. What are the potential problems with ET? So these are general big picture problems, but blood clots, arterial and venous blood clots, these are strokes, pulmonary embolus, DVT, bleeding, which is somewhat less common, but still can be an issue for some patients. And these diseases, as Dr. Hoffman was talking about, can evolve into other myeloid neoplasms, which is a risk that is shared by many of us. ET is often more indolent than PV or ET. So what does that mean by indolent? It means that it's a disease that tends to progress less reliably and less quickly than polycythemia vera or myelofibrosis. Median age is around 60 years old, but this is a disease where we have about 20% of the patients who are diagnosed relatively young age. Expected survival, and I asterisk this because all of these survival metrics are based on populations of people, not individuals. So if anybody tells you how long you're going to live, also have them predict the next lottery numbers, because I suspect they have about an equal chance of doing either one of those. We have these groupings of people because they help us kind of guide therapies. But any individual is not 50% dead in 10 years, right? It's kind of binary. And so when we think about it, we think of survival being longer as a group, but there are people who have real problems from ET early, and people who we think maybe should have real problems who never have real problems from the disease. And there's a lot of variability in these diseases we don't understand. And as I said before, ET is somewhat less likely to evolve as a group of patients. All right, so most patients have what we call somatic mutations. So what's a somatic mutation? It's a disease, it's a mutation that you acquire generally in your blood-forming stem cells at some point during your life. It's not one you're born with. It's generally not one you pass on to your kids. And why do you get them? Is our best explanation is kind of crap luck. We're bombarded by radiation living on Earth. Our beautiful glowing sun also throws out all sorts of nasty stuff at us. It causes mutations in our DNA. Sometimes we get the wrong mutation in the wrong cell in the wrong place. And so that can trigger these diseases. Ron pointed out some of the information that's recently emerged, and there's a number of these similar findings, but these mutations, the stem cells that become mutated, that initiate these diseases, and it's generally thought to be one stem cell at some point in life acquires the wrong mutation, evolves over time. And why that happens, we don't exactly know, but it can happen decades, many decades, before any clinical signs of the disease emerge. Of course, if 90% of people have one of these commonly identified driver mutations, that leaves 10% of people who don't have any, and we refer to them as triple negative. So how is this diagnosed? So the World Health Organization has criterion for ET, and I intentionally kind of made, my wife said this was an ugly slide, I apologize. But the high platelets is obviously part of the diagnostic criterion. Bone marrow biopsy findings. So looking at the bone marrow and having particular abnormalities associated with the disease is one that's necessary for the diagnosis by the World Health Organization. And then there's things that are like, it's not something else criterion. So it's ET because it's not PV, and because it's not myelofibrosis, because it's not a number of other things. And then the identification of these mutations. And these mutations have been helpful, right? If we don't have a mutation, then we're kind of stuck with squishy criterion. You know, is this really a malignant condition, or is this just a jazzed up bone marrow and extra production of blood cells for some other reason? And so having these mutations really allow us to focus in on the subset of people who have a clearly defined clonal origin of this disease, this mutated stem cell giving rise to the abnormal blood cells. If you don't have one of these mutations, so this is the triple negative people, if you don't have one of these mutations, then you can still have ET by virtue of some other clonal marker. So maybe another mutation. There are some other fancier, less used assays. And primarily this is when we eliminate other kind of reactive causes like inflammation or something like that. You can still be diagnosed with ET. So how is ET diagnosed? And, you know, it really starts very simplistically. Someone at some point notices blood counts are abnormal. And that can be you, often is patients, are like, hey, what's that? And you're like, oh, it's nothing, don't worry about that, it'll go away. And then it's still there. I'm like, okay, maybe we should check it out. And that's when we get to the second thing, which is somebody recognizes it and goes to a hematologist for evaluation. And that can be the patient, again. These are uncommon diseases, and we're stuck with this curse of uncommon diseases lead to most physicians having no experience with them. And so if you have your primary care physician, you may be their first ET patient. And so if you've never seen one, it's not the first thing, it's not top of mind, right? So they can see it, and there's a lot of causes for high platelet count, right? And, you know, they come and go. And so it's not unreasonable to kind of blow it off a little bit at the beginning. It'll get better. But when it continues, then that should warrant some additional evaluation, and that's something that can bring it to a hematologist. What do we do? Well, first of all, we try to look for potential causes of the high platelet count that can be explained by something other than ET. So what is in the clinical history that might explain this? You know, you have iron deficiency or, you know, whatever it is. And then laboratory evaluation. This is looking for, again, other causes that might explain or support a diagnosis of essential thrombocythemia. Physical exam, there are some findings. Most people don't really have any of them, but there are some findings that can be suggestive of an enlarged spleen or some skin findings. Sometimes, most of the time, no. And then mutation testing, and this is looking for those driver mutations, JAK2, CALR, MIPL, or other mutations that sometimes occur. And that can be very clarifying. Having one of those mutations, you really should get a bone marrow examination. Again, it's required for World Health Organization diagnosis. So if you have ET and you've never had a marrow, you don't really have ET. Maybe you have ET. You probably have ET, but you should have a marrow. So bone marrow biopsy is required and helpful, both as a baseline as well as to eliminate other possibilities that can masquerade as ET. And then once all of that is done and we have a diagnosis, what's the next step is really kind of like talk it through. What's going on? What's bothering you? What are the goals of therapy? What can therapy achieve? What is unlikely to be achieved? What's the timing? What's the natural history? What's your life going to look like? What do we want to do with this? And so that comes into, you know, how is ET treated? And so first of all, we want symptoms to be minimized, right? There are a variety of symptoms that patients with ET report. Those include things like, you know, I don't have my glass, but if I don't read them in the order, it's because I can't see them at all. But headache, itching, skin findings, burning, itching, difficulty with concentration is a relatively common complaint. Sometimes mood, sometimes not reported by the patient, but their spouse. Presence, difficult sexual health is a pretty common complaint. When asked, people are also fairly reluctant to offer it up if not asked. Less common, lightheadedness, dizziness, weight loss, et cetera, et cetera. But unsurprisingly, given this sort of diversity of symptoms that can be reported, there isn't one pill. It's not like, oh, you have this, I'll give you this, it all goes away. It doesn't work like that. And so patients have a variety, they each have their unique constellation of symptoms. They have some that bother them a lot more than others. It's important to discuss that because the goals of therapy should be oriented around making those most bothersome things better to the extent that we can, and to keep working on it if we fail, and sometimes and often we do initially. So what is kind of the other goals is to reduce risks. So, there are these clotting risks, and so we think about lifestyle. If you have ET and you've been a smoker, please stop smoking. This is the time, this is the motivation, right, to stop smoking, because this is a bad combination. So exercise, I think it's good. It helps with a lot of things. So if you don't, do. If you do, continue. Dietary factors, I don't know, but I think be reasonable. Pizza every day for lunch and dinner probably isn't in anybody's interest. But it has to be a diet you can live with too. So an extremely potentially beneficial diet that you can only do for 2 weeks out of a year, or one that you hate so much you kind of wish that ET had a shorter survival, then it's not a right diet for you. It has to be something that you can do, and hopefully for a long time. Other cardiovascular risks. So if you have high blood pressure, take it seriously. You have a box checked already for cardiovascular risk. We got to uncheck the other boxes to the extent that they can be unchecked. So cardiovascular risk factors like high blood pressure, diabetes, high cholesterol, they should be fixed to the extent that they can be fixed. And it shouldn't be good enough, right? I think it should be aggressively treated because these are compounding risks. Other health risks, just because you have ET doesn't mean other things don't happen. And in fact, there is some evidence to suggest that some of these other things you might be at slightly higher risk for. And so other cancers. So do cancer screening. I mean, it's important. Don't blow it off. Pap smears, mammograms, colonoscopy. Vaccination, to the extent that there isn't a good reason not to, I think should be done. In COVID, patients with MPNs with ET, for reasons that aren't clear, didn't fare as well, at least in some series. So it's important to try to prevent those risks that we can. Yeah, you already had that. That was my checkbox comment. There we go. So how is it treated? So we really kind of think about ET-specific therapy, try to predict your ET risk and adjust therapy recommendations accordingly. One size very much does not fit all. We have a couple different scoring systems to kind of predict thrombosis risk, and there is guidance around treatment based on that prediction of thrombosis risk. I'm not going to get into this. You may be familiar with it. But I just want to point out that low risk ET by this criterion has a much higher risk than the general population of having blood clots. So low risk is not no risk, and they shouldn't be confused. There's a kind of revised set that tries to tease that out in the low risk, in identifying a subset of patients who are at very low risk, and indeed, as a group, they are at very low risk for thrombosis. At least statistically, it seems higher than the general population, but I think it's quite low. And that comes into play with some of the treatment recommendations. But remember, risk refers only to thrombosis risk. What are the goals of ET therapy? Is really we're trying to minimize the risks of clotting mostly and bleeding usually as a consequence. decrease the risk of transformation. I put a question mark there because really it's in none of our guidance for treatment. That's kind of just left. All of our therapy is known and tested for its ability to reduce thrombosis. We really don't know very much about any of the agents in terms of their ability to prevent progression, other than we don't think many of them do so. Decreasing symptoms, so that's important, and it may not be with ET-specific therapy. It could be with other kinds of therapies. Even patients with low-risk ET can have a lower quality of life. A lot of them report symptoms. And those symptoms can be really quite bothersome. And if you are very low, you say, oh, you're very low risk, and you feel like crap. I mean, what's that, right? So sometimes there's other things that are coming into the decision to treat. And if you're not feeling well and there's a chance that therapy to better control the blood counts might help that, it is worth considering, and most of us do so. These are the general guidance from the National Comprehensive Cancer Network and the European Leukemia Network. They're very similar guidance, so I lumped them together. For the very low risk group, there's a question as to whether or not aspirin is beneficial, and I will hit on that in a second. But aspirin is generally recommended for everybody else. And then these recommendations, and there's some difference of opinion, I know, in this room on the topic, but I think everybody would agree, and those people in the high risk should be treated with agents to control the blood counts, so-called cytoreductive therapies, and there's a couple I'll talk about in a second. So what is antiplatelet therapy? This is usually low-dose aspirin. And why do we use aspirin? Because it can really help reduce the risk of clots. A lot of that logic, or part of that logic, is built from an extension of what we know about polycythemia vera. So aspirin can reduce the risk of clots in polycythemia vera. And so we believe that it should also in ET. And there are some studies to back that up. Aspirin can actually be miraculous for certain kinds of symptoms, a kind of skin burning, itching kind of thing. A baby aspirin a day or two a day can make that go away completely in some patients, so it can be very helpful there. What does aspirin do? It blocks platelet function. So platelets are important for forming blood clots. In ET or MPNs as a whole, they can be a little bit twitchy. So they can be a little bit more easily activated, and what aspirin does is kind of chill them out a little bit. And so, are there exceptions to everybody having an aspirin? Well, there's always exceptions, right? And so allergies to aspirin or having some toxicities like ulcers, we might be thinking about alternatives to aspirin-based therapy. Again, as I mentioned before, CALR mutated ET in this very low-risk group. It's less clear that aspirin is reducing this already very low risk of clots, and might even just be increasing the risk of bleeding. And patients with very high platelet counts sometimes have an acquired bleeding disorder called acquired von Willebrand's disease. And so if they have that, then we shouldn't be giving aspirin. And usually we screen people for this von Willebrand's disease if they have high platelets. If you don't have that, aspirin is okay. And so these cardiovascular risks, symptoms, all of that really kind of feeds into whether or not aspirin is recommended, but generally it is. Hydroxyurea, why do we use it? Because there's a number of studies that show it can reduce the risk of blood clots, and it's inexpensive and generally very reliable in this disease for control of the blood counts. People, I can write a prescription for hydroxyurea today. You can go and fill it today. You're not going to get hit with a $3,000 a month copay. So it's an available drug. And what does it do? I think of it as like a volume knob. You can turn down the volume. It slows down blood cell production. It will reduce all the blood cells together relatively non-specifically. Again, there are always some exceptions. There are specific toxicities associated with hydroxyurea. Some degree of mild nausea or diarrhea is pretty common. Generally, it goes away over time. Some patients really shouldn't take hydroxyurea if you are pregnant or trying to get pregnant, and that's both sides of the equation, should not take hydroxyurea. It can have some long-term effects on fertility. So if you're younger, you're looking forward to having children in the future, it's something to consider and maybe look for alternatives. There is an increased risk of skin cancers in people on hydroxyurea that's been recurrently shown in studies. They're generally low malignancy potential, but it is something, if you've had a melanoma before, if you've had a bunch of skin cancers before, that might come into the decision-making process. And like all of these drugs, it has to be titrated to avoid lowering the counts too much. I don't think there's any good evidence of hydroxyurea either encouraging or preventing progression in ET. I personally avoid it in people who have, in the very rare subset of people who have a p53 mutation for theoretical concerns, not actual data. I'm going to skip that slide. Interferon is an alternative. Why do we use it? Interferon works quite well in ET. It does seem to reduce clotting risk. It has a high response rate. It can be used in pregnant women. It can be used in people who are trying to have children. There's no long known effects on fertility, and it does not increase the risk of skin cancer. So it has some potential benefits. What does it do? It's a really good question. We don't know entirely. It does a lot of things. Basically, every cell in your body has a receptor for these interferons. But what it does, which I think is most appealing, is interferons can target specifically the mutated stem cells in MPNs. May not do that in every single patient, but in animal models, it works really well to deplete those stem cells. And in some patients, we can actually observe that over therapy. What are the risks? Well, like everything, there are always risks. Interferons, there are things your body makes during a cold or flu. So, symptoms like that, achiness, are fairly common. They're usually transient in my experience, in that this can go on for a little while and then goes away. You can't take these drugs, in my opinion, in most of our opinion, I think, if you have an autoimmune disease, pre-existing autoimmune disease. It's kind of like it'll stir the pot. Likely, the concern is it will make things better. So rheumatoid arthritis, lupus, no. Severe mood disorders. So this is one where you've had brittle depression and you finally are on the right cocktail of therapy that is making you feel better. I would stay away from interferon. For people with mild depression, well treated, not ever hospitalized, we use it a lot. I really haven't seen significant problems with that. Usually, touch base and work collaboratively with the person caring for the mental health, but most of them have no opposition to interferon in my experience. And then there's a risk of developing an autoimmune disease that you haven't had before. So that is a theoretical risk. It's something that has happened. I think it's incredibly rare, but it's always there lingering as a concern with interferon. More common is like autoimmune thyroid problems, and this happens, I think, fairly common, 10-20% of people. It's generally easily treated with thyroid hormone replacement. And then, like all of these drugs, we can have to titrate the dose if there's a blood count either up or low as we need to. And it's just important to point out that the discontinuation rate for hydroxyurea and interferon is about the same, but they're discontinued for completely different reasons. And so these are not one drug is good for everybody. There are some drugs that are better for some people than others, and that has to be recognized when making these decisions. And Negriclide, I'm okay on time, right? 5 minutes. Okay, I'm good. Chad, you tell me I got time. Yeah, it's like. So Negriclide is often is also used. I think it's less commonly used now than it used to be a few years ago, and that's although it is an effective drug at lowering the platelet count and it can reduce clotting risk, and it does so by selectively really reducing platelet production. It really targets the production of platelets from their precursors in the bone marrow megakaryocytes. But why is it not that well or not commonly used anymore? Well, there's been this emergence of data suggesting that it can be associated with cardiovascular abnormalities. So cardiomyopathy, arrhythmias have been observed. And so if you have underlying heart disease, we tend to stay away from anagrelide. It also can cause anemia over the long term, GI toxicity, which in my experience doesn't go away. It just kind of persists, so mild diarrhea that just is there for the period of time you're on it. And then there's been reports of kidney problems as well. So these are a little bit more serious and a little bit more common than we see with hydroxyurea, certainly, and with interferons. And so I think it's more of a second-line agent. It's still a good drug in many ways, but it has these concerns not shared by the other drugs. And so we talked a little, or Ron talked about progression. We talked a little bit about progression earlier, and I put a question mark on my earlier slide because none of our therapy talks to the risk of progression. And, the risk of converting to an acute leukemia is relatively low, but non-zero. The risk of myelofibrosis, as reported, is actually non-zero. And as time goes on, and of course we want our patients living 20, 30 years, then that risk is kind of accumulating in behind. And so, it would be important or helpful to know a little bit more about what some of those risks are. And so we looked in our patient cohort, and I just want to point out, this is predominantly, and again, I don't know why, maybe somebody in this room knows why, but it is predominantly a disease of women. 2/3 of patients are women. And in our series, there were around almost a third in this kind of very low risk group. So these are CALR mutated, younger patients who have never had a blood clot. And when you look at that, indeed, this green curve, which is those CALR mutated patients, they have very few clots. In fact, we don't observe clots in these patients. But if you look at the JAK2 mutated, the red, there's a significant incidence, even with appropriate therapy, of blood clots over time. And this is why this is very low risk. It's very low risk for blood clots. But when you look at progression to myelofibrosis, you see a very different picture. And when you look at the JAK2, they actually progress to myelofibrosis for a reason, again, I don't know why, but less frequently than those with a CALR mutation. And so this is so-called very low-risk ET. You have to put that in quotes because it's very low risk for thrombosis ET. It is not very low-risk ET. These patients have symptoms. These patients have a higher risk of progression. So it's great today. In 10 years, it's less great. And so that has to be kind of thought about in the context. And I think we need to make progress in terms of trying to reduce those risks. And we don't know how because we don't know why. And so this quick summary, first line, hydroxyurea, pegylated interferon, both good therapies. Neither one of them a great therapy for every single patient. So that has to be selected. Second line, there's a number of agents that can be considered, including ruxolitinib, I didn't talk about, and some other agents. And then there's clinical trials, and this is something that I think is incredibly encouraging because unlike 10 years ago, when there were no real clinical trial activity going on in ET, now we have a number of ET-specific clinical trials starting to get at some of these underlying important questions about how do we think about changing the natural history of these diseases. Reducing progression, hopefully, is going to make it into our targets of therapy, but for now, controlling the blood counts and reducing clotting risk remains kind of the central focus of therapy. But there's a number of agents which are completely non-overlapping in terms of their mechanism. And so hopefully we get some winners out of that. Some of the activity looks quite good. And I'm going to end there. I don't have thank you slide. This is Ellen's fault. She didn't put thank you slides on.
Thank you, Dr. Scandura. I'm sure Dr. Ritchie will be proud of your talk. So wonderful overview on ET, and obviously we need to do better long term and prevent progression, which kind of ties into Dr. Hoffman's lecture.